Hello, guys. Am I audible? Okay. Hope I'm audible. Okay. Welcome to another class. Let's start. Okay. We'll be diving into anesthesia today. 24-year-old patient is brought to the ER unconscious. Information he has no gag reflex, which of the following eight videos is most appropriate to use. See, three buzzwords. No, he's unconscious. He's unstable. Like Giddles is the more appropriate one to use. Okay, leave that. What are the options we have here right now? Oropharyngeal airway is the one, I guess. That is the one. That is my bet. Nasopharyngeal airway. Not sure. Trauma patient is there. Has no gag reflex. I'll just go with A. We'll see. बोनी करना है अभी. उसके बाद we'll see. Okay. Patient no grab reflex. Classic setting for A use. If you are unconscious, opioid trigger gag reflex. See, if he was stable patient, like in this similar scenario, if he was a stable patient, we could have used nasopharyngeal airway. The B we could have used. Endotracheal tube, it's not the use case right now. We don't need it right now. Endotracheal tube. When do we use endotracheal tube? Not for this, right? Okay. Laryngeal mask airway. Okay. Laryngeal mask airway. First generation, second generation. Not for this again. Supraglottic airway, like laryngeal mask airway and supraglottic airway is both are the same. First gen, second gen. The difference. We'll just go through what chat has to say. After that, we'll head towards the next stuff. Buzzwords and damage relief. Elimination. NP used in unconscious or semi-conscious patients because it does not cause gag reflex. It does cause, okay. Nasopharyngeal airway does cause gag reflex, but okay. This is the best use because nasopharyngeal airway is better, but in conscious patients it causes gag reflex, so we can't use it. NPA does not cause gag reflex, so it is suitable for conscious people. PT tube, definitive airway, but stem masks most appropriate. Immediate device. Did it ask? Not sure. We have one viewer. Hello. Yeah, some people are saying I'm whispering or something. Okay. One person is there, but still fine. Better now? Anyways, we'll continue. Laryngeal mask airway and supraglottic airway devices both are same. SADs and LMA used when intubation fails or in elective cases. So like this is the next step. So in all the airway device, intubation techniques, like there is a sequence. If one fails, we go to the next, then we go to the next. So basically, oropharyngeal airway or nasopharyngeal airway is the primary which we use for the immediate action, and these are the easiest to these are the easiest and quickest procedures we can do. Okay, so OPA only in unconscious, OPA can be used in unconscious. Genie saves us. Yeah, okay. Another thing, tongue fall is there. Tongue fall we forgot to discuss. See, giddles or a pharyngeal airway. These for this you need to know the name. Oropharyngeal airway, giddles. In that we use it in unconscious people because in unconscious people, uh, this thing as chat has said, genoglossus prevents the tongue fall in conscious people. When they're unconscious, there is a high chance of tongue fall. So to prevent that, we use that. And what this because giddle's oropharyngeal airway is C-shaped, like it's an inverted horizontal C. So it keeps the tongue intact and prevents it from falling. Okay. Next, this exact differentiation OPA versus NPA has been a repeated need. Okay. Key exam trap. Many students. Hey, we have first comment. मजे मजे ही मजे. कौन है? श्रेयस है. Lol. Okay. Many students mark NPA thinking it's safer, but the absence of gag reflex plus unconscious OPA is the answer. So basically, you see, in the first uh, primary treatment, like for the immediate, what we can do is put in OPA or NPA, and under that, which one you use depends on the patient status, right? After that, you move on to LMA or SGA. सर अली गाना से भाई मिल जाएगा चेतन तेरे को, चिंता मत कर. Thank you. Okay, let's move on to the next question. Intubation of 35-year-old male under general anesthesia. Anesthetic test wants to confirm correct endotracheal tube placement. Which of the following is the investigation of choice to confirm placement? ETCO2. See, investigation of choice when they ask, it is always capnography. Only when, like, if capnography is not there in the options, go for chest X-ray. Hey, Shreyas, your exam is done. Go sleep. Okay. Capnography is the answer. So, okay. We'll discuss one by one. Shark fin is Macintosh, no? Hey, you are talking about capnography. We'll see. We'll go step by step. Who's that? Chetan, no? Beat your ass, fucker. Shark fin was in what? Hey, correct. Thank you. Shark fin was COPD. Capnography. Okay. We'll go one by one. We'll discuss this and then we'll move forward. Shark fin COPD, it was correct. Why did you delete the message, idiot? Okay. Confirm EDT placement. The exam loves this. Lol. In station, they want the most reliable and immediate method. I'm not sure about capnography being immediate method. Only if the patient is being monitored, this thing will come up. Okay, but in a primary setup, not sure. What the fuck are you guys discussing? Shark fin is COPD da. Okay, both are possible. What? I'm not sure. Okay, we'll continue. Chest X-ray, floor delayed. Investigation of size and negative leave. Auscultation is not the right one. Human error. Okay. Pulse oximeter tells you oxygenation but doesn't confirm tube position. SpO2 may stay normal for some time even if tube is in esophagus. Okay. Capnography gold standard. Presence of waveform with ET CO2 confirms tracheal intubation. See, presence of waveform with ET CO2. I'm not able to find a picture to show this. Okay, we will see. Although if there is a specific question for capnography, we'll pull up a capnography picture and we'll deal all of them at once. For now, let's keep it aside. We'll move forward. Investigation of choice to confirm position of ET tube entitled CO2. Okay. Highlight capnography pattern, sharp fin, obstruction, sudden loss. Shark fin, Goma, where did you go? Da? Chat is saying something. Please, somebody cross check if you guys are alive. Multiple names, okay. We'll go for the next one. Obese sedentaries male with a short neck is posted for elective surgery. On airway assessment, the uvula is not visible at all. Which of the following is the correct Malampatti? Short neck, difficult airway. Malampatti will say uvula is not visible at all. So grade 4. Okay, Malampatti will. Okay, we'll do the whole Malampatti once. I'll need an image. Just a second. Huh? Need to sort this shit. Okay. The only problem with ChatGPT is there is no image context in this. Elimination trick. Okay. We'll see. There are two ways of dealing with this in Malampatti. The method which ma'am has taught is using uvula only. So like as chat is, I think it's referring to the beta transcription only. So grade 1 entire uvula is visible, grade 2 tip of uvula not seen, grade 3 only base of uvula seen, grade 4 is no uvula seen at all. But you also need to, this is Malampatti classification, the classic one. Samson Young's modified Malampatti classification, in that like few more things on which the questions have come is like the soft palate and hard palate thing. So like you need to know until where soft palate is seen and in which one soft palate is not at all visible. In grade 4 soft palate and uvula both are not visualized. Okay, grade 3 soft palate and only base is visualized, only base of the uvula in grade 3. Another important thing which they concentrate on is the tonsillar pillars. Okay, in grade 1 of Malampatti, the tonsillar pillars are clearly visible and throughout their breadth, like whatever is the orifice in visually when you see, the whole of the pillars are visible. But in grade 2, only the top half, like the upper part of the tonsillar pillars, the fauces is basically the background, uh, the fauces and soft palate is seen, including the uh, like except for the tip, the rest of the uvula is seen in grade 2. This is the tonsillar pillar is only visible in completely visible in grade 1, partially in grade 2, not seen in the other two, and soft palate is visible in all three except for grade 4. Okay, just make note of this, otherwise you're golden. The next you see base only, yeah, in grade 3, see nothing at all. Grade 4, okay, the same thing. Malampati classification repeatedly seen. See, this much तो you should know at least. मुंह में देखना, like एटलीस्ट पेशेंट के मुंह में तो एक बार देखा होगा, दैट 15 दिन के इंटर्नशिप में इतना तो दे एक्सपेक्ट. Malampati uvula visibility decides grade. Okay, grade 4 no uvula seen, only base of uvula did not seen. Okay. Next, why is it showing the during an emergency trauma case, the anesthetist applies cricoid pressure while performing rapid sequence intubation to prevent aspiration. Celix, no? Yeah. Hey, why are you giving me the topic beforehand, idiot? Okay. Celix. We'll discuss all of these at once now. Heimlich maneuver used when it's like in choking. Larson's maneuver is like the pressure is given behind, like inferior to the ear. This is to prevent laryngospasm. Larson's maneuver. Celix is the answer right now. So it is used in rapid sequence intubation. This is for like like in cases of fasting or like prolonged malnutrition or something, like basically in emergencies it is used cricoid pressure to prevent aspiration. Okay, we will see. I am not able to recall properly. Celix, cricoid pressure prevents regurgitation and aspiration during RSI. Okay, applied behind the ear, alarmonic to break laryngospasm, not aspiration. Yeah, this is there. Next, Heimlich, abdominal thrust for choking, foreign body. Okay, jaw thrust lifts tongue and mandible in airway obstruction, but not RSI aspiration. Jaw thrust in airway obstruction. Okay, this is, I think, to increase visualization, I guess. I'm not sure. We will see. Your BTA notes explicitly mention cricoid pressure and aspiration prevention. Larson says to prevent laryngospasm. Okay. Next. In laryngoscopy, only the epiglottis is visible. Only the epiglottis is visible. Vocal cords cannot be seen. What is the Cormac line? Grade 1, all vocal cords incomplete. Only epiglottis is grade 3. C. Cormac line grade. In this, we grade it using the visual output we see in the laryngoscopy. Okay, so we judge it based on like the visibility of the vocal cords and epiglottis. Okay, in grade 1 we see the full vocal cords. In grade 2 partial vocal cords are seen, not completely. Grade 3 only epiglottis seen, no cords. Grade 4 nothing is seen. Okay, this is okay. We'll move forward with this. Grade 4 nothing visible frequently, sometimes combined with malampati. Both predict difficult intuition but assess differently. Okay, next. Attempting intubation, the anesthetist fails to intubate after 3 attempts with direct laryngoscopy, which is the next best step according to the difficult airway algorithm. Okay, there is plan A, B, C, D. Okay, keep trying more attempts with same laryngoscope. No, three attempts has been done with direct laryngoscope. There is no point in doing it like a few more times. Attempt supraglottic airway device. Yeah, this is the ideal next step. Immediately proceed to surgical tracheostomy. This is overkill. Wake the patient up. Gone mad or what? No. Answer is B. Failed intubation after 3 attempts with lateral laryngoscope. Exactly the cutoff in the algorithm. See, in the original difficult airway management in the algorithm, face mask ventilation and like tracheal intubation direct is done 3 times, maximum 3 times. If direct laryngoscope direct intubation is done, tracheal intubation is tried 3 times. You can try one more time if the CMAC is a CMAC can be arranged within that time. Otherwise, it's fine. Next, in plan B, second generation SID insertion, second gen LMA can be used. Supraglottic airway device or laryngeal mask airway. Okay, the same thing in this also, max 3 attempts is allowed. If it is failed, then you can only give face mask ventilation because there is no other option, like there is no other viable option at this point of time. But if it still fails, then at that point front of neck access needs to be done and scalpel cricothyroidotomy needs to be done. In that cricothyroid membrane is pierced. Okay, keep trying wrong. Okay, no, SAD is the correct one. Surgical tracheostomy drastic, it's not needed right now. Can't intubate, can't oxygenate, last resort. Okay, become patient option in elective stable cases, but not okay. Not completely a mad option, but ಒಂದೇ ನಿಮಿಷ. Okay. We'll end it for now. I'm feeling sleepy. Good night, boys.